Hi, everyone. Thanks for being here. My name is Sam Miles. I'm a fifth-year PhD student at UC Berkeley in the Renewable and Appropriate Energy Lab. I'm here presenting our paper, Internet of Things Could Shape Healthcare Facility Electrification, Evident from the Democratic Republic of the Congo, the DRC. Now, this is a large team, so I'm just throwing up, you can see there's like 13 co-authors, and shout out to the ones that are actually here with us today. We've got Ryan, who's here, second author. We've got Mario, China, Valentin, and then, of course, Dan and Gina. So this was a big team, and so we're really excited to present this work, I think, for the first time in a sort of academic research setting. So just to sort of enter, thinking about what Dan mentioned yesterday at the plenary talk around how justice as an additional constraint might actually reduce the complexity of problems. You typically think of adding constraints as making it more complex. Here, we're going to look at the applied case of health facility electrification as a tangible, concrete example of what it might look like to impose a justice constraint in order to clarify a problem, to make it more concrete, more actionable, more visible what the next steps are. So this is happening in the context of a broader global effort at electrifying health facilities, in large part spearheaded by the US government. So just having that perspective in mind, that it's not just an academic exercise that we're thinking about in theory, but rather observing changes happening in the real world, and if we're really lucky, even participating. So just as a little bit of background on electricity and health, because this is not actually a new topic. It's an old topic, but one in which there hasn't been enough progress in the past decade. So starting out with this landscape, currently in Africa, about a quarter of facilities have no form of power source whatsoever. So none. About a third of those have what we consider a reliable power source, but that definition of reliability is not what you think of from power systems. It's actually a survey question that we look at in a bit. Now, the consequences of that are, from the quality side, to say nothing about reliability, is that about a third of equipment are estimated by the WHO to be defunct as a result of power. So the impacts are pretty strong here. Now, the data behind that isn't rigorous, but that's the kind of what the WHO thinks. And then lastly, of course, we don't care about electricity for electricity's sake. We care about for what it does. And in this case, we're talking about health impact. We're talking about health facilities. We're talking about hospitals and health centers. How does electricity impact people's lives? Now, where is this a problem? If you look at, globally speaking, where there are energy deficits, the DRC, the Democratic Republic of Congo, is one of the countries with the largest energy deficit, the largest energy poverty. You can see here in this graph. There's actually an estimation from satellite imagery at night. So when you look at the world at night, you can see where there is no lights, where there's no power. The DRC, both on the rural and the remote side, sorry, the rural and the urban side, kind of a standout. 100 million people, 9% electrification rate, roughly. So in the time that we have been doing this, we have realized that it's been challenging, actually, to ground people in the realities of what power means for health. So in the next couple of slides, I want to show a couple of pictures that just sort of illustrate this intersection, and want to say that these are from the last 2 weeks. We just came back from the Congo, and all kind of folks who were photographed gave verbal written consent. That's just FYI. Never mind, that's right after the slide. So in order to sort of ground these things, we wanted to tackle this evidence gap and pilot novel methods for collecting health facility data that were precise, scalable, and real time. And so we wanted to start in North Kivu. Now, why North Kivu? It actually has one of the most dynamic and diverse energy sectors in the Congo. In this place where we have a lot of energy poverty, this is the place with literally the most activity. So we were interested in starting there to see how we could characterize the landscape. And then lastly, orient the research outcomes towards things that change, things that are have the momentum to actually improve, not just observe. Now I think we're at the picture. So right off the bat, we can see a couple things here that are electricity. This is lampe cialytique, an operating lamp. Obviously, it's hard to operate on a patient at night if there's no power. You can see here a vitals monitoring sign. This is a typical surgery room. In the diagnostics imagery, of course, we can't do x-rays without a whole bunch of electricity and voltage. Obviously, we've got our printers here, our regular ICT equipment. Then there's the perhaps less obvious ones, is where is this power coming from? Is it the grid, or is it the generators, all the plethora of power sources, and what is it used for? This is an important case, is an oxygen concentrator, purifying oxygen from the ambient air, feeding it directly to a patient. What happens to this equipment when it breaks? It gets You put it in a graveyard, it gets mined for parts, it gets replaced, and there's this constant rotation of how do you keep not only the lights on, but the patients alive. And that is a function of equipment. So just a sort of grounding of the different ways in which electricity is used in health facilities. Now, here what we have is sterilization. Typically, when we do sterilization in a health facility setting, that involves some kind of heat, right? Like you disinfect through an autoclave or a sterilizer, whether it's boiling water. In the absence of the energy to do this easily, we wind up with disinfecting processes that are less modern. So that was the sort of slideshow component. So let's zoom back out. We are now doing research again. Let's explain what we did to sort of uncover this problem. So we, first of all, made a partnership with the local NGO, this Research Center for Humanitarian Aid, a Goma-based NGO. Goma is the capital of North Kivu. And with them, we essentially approached the health department and said, what do you know about your energy? And would you like to know more? And they said, we know nothing and we want to know more. So we signed a partnership agreement with them to select some facilities to observe. We selected 25, and that's a question of budget. With these 25, we broke it down to the top of the referral pyramid, which is the hospital, the provincial hospital responsible for the 9 million people in the province, down to 10 out of the 34 referral hospitals. There's 34 health zones and therefore 34 referral hospitals, one referral hospital per zone. Then 5 forward hospital centers, which are the same thing as the hospital, just not referral. And then referral health centers, which are essentially remote rural hospitals, and then some health centers. So the interesting thing to note here is that we got a selection from across the health pyramid, all of it, and that all of the sites were kind of aggregated along this principal urban density corridor between Goma and Beni Butembo, the cities in the north, with some outliers in the rural regions, such as Adria Walikale, here in Walikale, and Adria Oicha in Oicha. So I mentioned a diverse and dynamic energy situation, and so we weren't kidding. So North Kivu is one province, and we've got 5 facilities on the state-owned utility. We've got 11 facilities on multiple commercial grids operating in the same province, some of which in the same city. Then we've got 5 that are on their own community microgrids in rural regions where there's a sort of local government or local church funded hydro project that will power a couple small towns. So like the informal community level microgrid, and then of course the 5 that are on their own system, whether that's PV, generally some kind of hybrid. So we got a really broad spread of power sources and health facility types, like everything you could imagine. Now, how do we compare these different things, these different sources that are not only different energy types, but different power sources? Some of them are hydro, some of them are solar, some of them are thermal. Here's the sensor that we use. It's called a Power Watch. It's manufactured by a company named Nline that was spun out commercially out of UC Berkeley PhD research. And methodology entails installing 2 to 3 sensors at each site so that when they both go off at the exact same time, it's an outage and not simply that a cleaning lady or a cleaning gentleman unplugged a sensor. They measure power interruptions and duration of outages in this way by coordinating when the 2 sensors or 3 sensors go off at the same time. And a single sensor can also provide granular readings on voltage spikes and sags, as well as AC frequency at a regular interval of 2 minutes continuously. So plug it in, 2 minutes, the next 2 minutes, the next 2 minutes, you're getting a batch of data. And that gets sent over cellular, 2G or 3G, to a cloud platform that we are accessing in essentially real time. And there you can just see what that looks like installed at Heal Africa. It's a hospital in Goma. So just to sort of look at one single sensor, one single site, what this looks like is we were fortunate enough to install it at Cesar Kiziba, which is in peri-urban Goma, a couple of miles north of the city into Nyarugoma territory. You can see that what they were using at the beginning was a kind of own facility microgrid, which is just a couple panels filling a lead acid battery with what they call an electric change machine, which is an inverter, but really, because as you can see, it doesn't really keep a stable voltage. The voltage that it produces, this is the sensor that's reading what this is powering the outlets at. It goes up and down with the sun. Essentially at noon, it's at 300, which is not what you want for 230 nominal. And at night, it's going below 100, which is, again, not what you want. Then we got lucky that they got connected to Nuru, which is a 1.3 megawatt solar mini grid, metro grid, they prefer, in peri-urban Goma. And you can see a stark difference in terms of the quality and stability. So that's a kind of evocative use case, but 25 facilities. So this is what that kind of looks like at all 25 of a single week. Again, you want that 230 range, plus or minus 10% for voltage. And we're seeing some extreme outliers here with 324 volts at some facilities. So you can imagine what kind of medical equipment you're putting on at 350 volts. And same thing at Kirumba, you're getting 130 volts on average. You're not getting much more than light bulbs. So you have access, yes, but you're not getting the benefits. So zooming out, we can just do this over time. So this is the 6 months. So 25 facilities, voltage at each 25 facility over 6 months in one graph. And you can immediately see sort of the outliers here in terms of voltage. If you notice, they're all CSRs, which is kind of giving us the insight that voltage stabilization is potentially a thing specifically for these rural hospitals. We're seeing that this is a recurring issue. This is the kinds of insights you can get when you have sensors out at a fleet scale or at a portfolio scale. Not at the single facility scale, but at a portfolio scale. So same thing, we get to learn a little bit about outages. What's the profile of outages in this region? Here we've got all of outage duration over 6 months, and we got a spectrum. So we converted the hours over the 6 months into a simple uptime percentage, drawing inspiration from the water sector, actually, where there's some results-based finance mechanisms that utilize a similar methodology. And the key takeaway here is that there's a wide spectrum. The lowest ones in our sample got power 77% of the time. Once you start getting into the more advanced facilities or the better facilities, you start to get into the world of reliability that we're a bit more familiar with in the West, where you have the number of nines, right? 99.9, 99.999, that's the number of nines, 4 nines, 5 nines, 6 nines. It's not just the outages that matter, though, in terms of how long you don't have power. Even a short outage that lasts a couple seconds or in a healthcare context, that can matter a lot. You can imagine when a physician is doing a blood test, for example, machine might need 20 to 30 minutes to run the sample on the hemoglobin or what have you. Power goes out for a couple seconds. That's a power electronic. It might shut and you lose your sample. So you can't do the diagnostic test. So even the things that you might not expect about power to be impactful, they might be. They are. So again, we don't know yet at this point when we start to research what is important, and the health department doesn't either because it's not in their mandate. The health department's job is not to measure power. Their job is to keep people alive, particularly in the context of Eastern Congo, which, as you may know, is fraught with geopolitical stability going back decades for a number of reasons, which we will not get into in this presentation. Lastly, I just wanted to throw this out for this crowd because this is something that I haven't been able to get a lot of feedback on generally when we talk about this, which is frequency. We typically think of frequency drifts in the West as 0.1% off of nominal 50 or 60 hertz, maybe 0.2%, maybe in extreme cases 1. What do we do with this? This is nominal, 50, and this is plus. I think this is, yeah, so we're at, so I'll just leave this for your appreciation and we'll come back to it. So after a year, we say, okay, let's just take all of our data and figure out a comprehensive way to compare all the different things. So this is the PQR aggregate score that we came up with, and this is where we want this crowd's feedback on. So very quickly, pretty simple. We just took a simple average of quality and reliability, quality as a function of voltage and frequency, reliability as a function of outage duration and frequency. Now, for voltage, it's plus or minus 10% off nominal, 230 volts in the DRC, not too controversial. We went with 5%. So that's sort of, we're hoping we can get some electromechanical engineers can sort of maybe help us think about how you quantify the impact of unheard of frequencies on biomedical equipment. And then lastly, on reliability, it's that uptime score we talked about. You take a simple average of mean duration outage and mean frequency of outages on a daily basis. So then it gets you able to say 0.3 outages per day or 3 outages per day on average. So it's a figure that we can all intuitively grasp. So just for context, the existing threshold for reliability, as defined by the WHO, is a survey instrument that goes like this. Have you had an outage of 2 hours or more in the past week? If yes, you're not reliable. If no, you're reliable. Now, that is a survey tool that is administered when a census is administered. In the DRC, that was in the mid-80s. So as a proxy for reliability, this doesn't really cut it, right? So let's compare this 2-hour reliability in the past week. If you do 168 minus 2 over 168 hours in a week, you get a 98.8% uptime, just to sort of ground ourselves in this framework. Now, how useful is that compared to something where we can at least say, well, the things that get us from a 1, where it's an extremely limited access, maybe a below 50% PQR score, again, we came up with this, to get it to a low quality reliability, 50 to 90%, which is different from decent quality, maybe between 90 and 95%, you know, an A or A plus, which would get to a 95 to 99%, and then excellent would be 99 and above, 99.999, etc. So this is a mortality agnostic weighting. We needed something to be able to quantify and compare. And now I'm going to hand it off to my colleague Ryan, who's going to walk you through the next couple of steps on how we think about refining this methodology, or rather refining the slices, refining the tiers in a way that can get us even more responsive to the thing we care about from an energy justice perspective, which is, in this case,
Can I just talk loudly and everyone can hear me, or do we need to do this? Where's that?
we might be on Zoom though.
Oh,
There we go.
right.
Up, down. Okay.
I'll figure it out. All right. Well, I'm gonna put this there. Thanks. So my name is Ryan McCord. I am a PhD student at Duke University, studying environmental economics. And my focus is really on sort of energy and health nexus work. And so that's how I got looped in to this project with a bunch of Berkeley researchers. So as Sam just mentioned, we have this effort to sort of categorize health facilities based on this index of power quality that, again, we sort of came up with. And so taking this a step further, we want to move to a framework where we can use health outcomes, and we'll talk about mortality today, as a way to define where some of these comes should be, right? So at what point do you move from a level of mortality that we're okay with, we find acceptable, to where we're not, and how can we feed back and figure out what that split looks like in terms of power quality. And so we have just started this part of the work, and it will be a very simple version of some machine learning compared to what a lot of people in this room do. But I will just show you some very initial results we have from our first batch of data. And so the first results I'll show you here are the results from comparing random forest model, where we input just those 4 initial indicators of power quality, right? So frequency, voltage, outage duration, and outage frequency. And we're comparing that to actual mortality rates. So you can just see how well this model is predicting actual mortality rates in these facilities. And again, the only thing going into this model is just power quality indicators, right? And so we are doing a surprisingly okay job, not considering number of patients at a facility, number of staff at the facility, or anything else, explaining some of the variation in mortality that we see. Of course, we do a little bit worse. We do significantly worse when we get to places that are having really high mortality rates. This is something that we are working on now. Again, we've sort of just gotten access to some of this health outcome data. So taking this a step further, this is also results from the random forest models that tell us a little bit about which of those dimensions of power quality are driving more of the variation in the mortality rates that we see, right? And so you guys maybe who don't think about power quality and health, and I would say myself even coming into this, might think that outages could be driving a lot of what we see here, right? Like if the power goes out, you can't really do anything. But when you start to look at this data, in multiple versions of this that we've run, with and without things like seasonality being considered, voltage comes out as sort of the most important predictor of mortality rates. So this is something that we can say, we start to put a story together, but we want to really then be able to zoom way back in and say, okay, we see which dimension of power quality sort of for total mortality matters most, but we want to be able to get to the point where we can say, well, where would we intervene to improve this? And from there, we might break it down further and look at individual sort of mortality rate outcomes. So is it the same story for total mortality as with maternal mortality or neonatal mortality? And the short answer is no. So this Sankey diagram just shows you, if you run that same random forest model for these outcomes one by one, you can see that for some outcomes at the top here, those outage, those reliability metrics are relatively more important, right? So if you think about something like surgery, you can see that the outage frequency is driving a lot of mortality in that case. So this is what we're sort of taking, we're making an effort to zoom in a little bit further. And so current efforts are really focused on zooming in even further and thinking about one point at which we could intervene that could be explaining a lot of the mortality that we see. And that is oxygen. So this is not data driven. This is just to sort of give you an idea of some of the ways that we're starting to think about the pathways between power quality, where oxygen shows up in the provision of care, what kinds of services and disorders are related to that, and then which kinds of sort of actual deaths that could be attributed to oxygen. So Sam could tell you a little bit more about some additional sensor work that we're doing, specifically related to oxygen facilities, but sort of this big picture down to the really zoomed in story that we hope to be able to replicate with other kinds of services at facilities to get to a point where we can back sort of all of this back out and redefine this sort of tiers of health facility electrification in a way that is no longer mortality or other sort of service delivery. Sam, anything else you want to add?
Yeah.
Sure.
Thank you.
Would you like this book? Feel free.
Thank you, Ryan. Thank you, Ryan. We are really lucky to have you with us at Berkeley. Berkeley.
Last thing I wanted to say, so thanks for your attention. We mentioned energy justice, we mentioned how we get to action. These are sort of the next steps from the implementation perspective. Basically, with this amount of information, with this data, with this longitudinal data, which is kind of leapfrogging a sort of gap in evidence, we have been able to bring together a coalition of partners that are sort of data driven, including the US government through various development initiatives, including Health Facility Electrification Telecommunications Alliance, which is a global development alliance aimed at using public funds to crowd in private sector financing and private sector partnerships, including the project that you're seeing here, which is a snapshot of a couple of pictures from 6 facilities with an intervention treatment in North Kivu and 4 in Kasai, for a total of 10 facilities that have now received a critical circuit intervention where a solar plus storage plus biomedical equipment package is installed in the ICU, with the hypothesis that isolating oxygen concentrators from power quality deviations in the intensive care unit, we should be able to see observable reductions in mortality rates. So that's the hypothesis. That's what we are aiming for. Here is the installation. This has been 4 or 5 months now, co-financed upfront by the US government, the US private sector, and a local NGO. This money is now turning. Facilities are paying on a monthly basis, like an energy as a service model. So not like, $1,000 for the product, but rather $50 per unit per month, and they are paying. So that's an interesting sustainability model. You can see here just some epic pictures from the Congo, just like a very ununderstood spot in our opinion, but installations, off-grid box flex, smart solar inverter, solar panels, rural thing. So again, just some snapshots to let you know what implementation looks like. Now, just to close off, because I think we're probably over time already, just some next steps from our end. We would love some feedback on this PQR methodology process that we're going through, and we want to take advantage of the fact that we have a bunch of power systems people and electrical engineers in the room who can give us some commentary on frequency like standards, voltage, frequency, SAIDI, SAFE. It's not really SAIDI, SAFE, but it's outage duration and outage frequency. We can get there. So please, we'd love for you to get your feedback on that, and you have some of our email addresses up there. For all things, our numbers, stuff there, but for all things RCT, all things econometrics, please reach out to Ryan. We'll talk to Ryan right now. Our email address is up there. We talked a little bit about oxygen. We have Valentin, who is a visiting scholar from ETH Zurich, who is taking on a bunch of work on the supply chain delivery systems for oxygen. So anyone who knows anything about solarizing devices or electromechanical engineering and processes, reach out to Valentin. Lastly, we're in our fundraising stage. So anyone interested in impact metrics, dollars per dailies, different kinds of epidemiological standards, Mario Fontes is here from Effective Altruism at Berkeley. And then me, I'm obsessed with mini grids. So anyone wants to talk about mini grids or remote monitoring, I'm here. And then lastly, China Duff on innovative surveys. We collect a lot of qualitative information from chatbot built on WhatsApp. So here are our faces, so you can identify us. I think that's it. Last one to say thank you very much again. If you want to learn, go straight to the source and figure something out about the Congo. This is our research partner on the ground. Couldn't have done anything without him. Jackson Nguma, shout out. And yeah, thank you.
Yeah. All right, we invite some questions if we have any.
I thought it was a great presentation. I really enjoyed it. And the frequency deviation, is that due to substandard equipment or what's going on?
Good question.
So we are in a unique situation in the Congo where we don't have a single interconnected grid. It's not unique. You can look at Niger and Chad, and you have some countries where you don't have an interconnected grid. What we have here is a plethora of small hydro. So our hypothesis, I don't have proof for this at this point, no one, but we've been talking to people and we think this is true, that this is essentially a direct function of environmental change. This is a direct function of pluviology and hydrology. So these small hydro systems are between 50 kilowatts and 600 kilowatts. So, or 8 kilowatts, I should say. So they're at all levels of scale. They were built between 10 and 20 years ago, sometimes artisanally, sometimes piece by piece. The river changes. So with the river changes, the turbine that is set to convert the flow of the river into a 50 or 50 hertz frequency, that's where you get your difference. Over 10 years, the river gets faster, your frequency is now turning faster. River gets smaller, slower. So it's not a function of demand. Our hypothesis is that this is a direct environmental cause.
So the systems are quite old.
Many of the micro hydro systems were built in the 80s and 90s by, in particular, Italian monks.
And no frequency controls on it. There's a weird, there's a generator.
Yeah.
Not like I read.
Okay.
That's our so Brian and I are both Link fellows, and part of like my pitch was to go into this environmental question, and then everything just took like a real left turn into mortality, into oxygen, and so we would love to explore this more. The data set to test this hypothesis is a little bit challenging to come up with because we don't have good resolution climatology data in this region. Like we talked to their volcanic observatory people, or the only people who have meteorology stations, and they don't have enough power to collect the meteorology data. And they've been on strike for 5 months because the government hasn't paid them. So no one's looking at the volcano, which is another aspect of doing research in this area that's concerning.
Well, I suppose the cost of micro power electronics comes down quite a base. So I'd imagine that there could be solutions out there that could rectify this if the finance was accessible.
At like a facility level.
Yeah.
I would love to learn more about that. Then there's a question of cost, but at least that could get, fed into the WHO system of power quality standards. Like they are already defining the kinds of voltage stabilizers that they're going to mass cure and then distribute country to country. Now, I'm not sure how bad of a problem this is across the rest of the continent. I can tell you that in the Congo, it's a lot because we have a ton of hydro, but most of the continent is hydro valley. Not to say that most of the continent is micro hydropower where this is a particular issue, but it's not documented. Like we have no way of, like there is no literature that I have found on frequency disturbances in African grids. Zero.
Yeah.
Well, certainly in this part of North Kivu, there's basically no spinning reserve. So this is all run
Like a period of case South Africa, it's all about old.
exactly. So this may be the case here. I actually wonder if some of the bigger units, when they ramp up AC and operating rooms, don't have an effect too, but we don't have that data yet. Although with these inline sensors, we should be able to pull that in. It's just a data issue.
Yeah.
And the voltage is very fast.
Right. Yeah.
And if you go back to your new mini grid, metro grid, whatever you want to call it, it's a pretty, you can see it in the data. Oops.
Yeah, and so these things are ubiquitous. Made in China, available on the local market, electric change machine. Well, nothing against that per se, except that this is the only thing that's available, which is good because some power is better than no power in some senses.
Stabilized, call it.
I hope not. It's technically called it's electric change machine is what it says on it right here.
Change machine.
Meaning it's an inverter, right? It's converting from DC power to AC power. However, it does not maintain stable voltage nor stable frequency either. And you can see like, these are analog switches. And they're extremely ubiquitous, like in every remote place. Well, we have data on exactly how many facilities have just a solar or just, what they have. Pretty much everyone that has solar, they have one of these. Otherwise, they have to have DC only lights, right? And that's hard to get. So they get one of these. And then at least with this, you can start to plug stuff in. Unfortunately, that's not going to last very long. I mean, under voltage is perhaps not as concerning from a biomedical equipment perspective as over voltage from a destruction perspective, but like you're just not going to be able to get the thing working at all without a sufficient voltage.
You'd probably destroy the equipment to fill over time.
And-
And that's the thing, like if you poor power quality, if you may not, the equipment may last for a while, but then like.
The lifespan,
Like
degradation. And so this is again the supply chain question because 80% of all the equipment is donated in the first place. It's all different kinds of brands and it's all designed for the West, meaning that when you put it in an African context, you're like when you look at the tech specifications for these devices, it doesn't have anything for frequency because frequency deviations above 2% don't happen in Europe. So the manufacturers don't even put a spec sheet for it. They just say don't keep it too close to an electromagnetic pulse. That's like what they think about when they think about frequency.
Well, you're not even talking about just power, you're talking about, they get really dusty, or they're exposed to heat, or they're whatever, right? Like, there's all these other things.
So again, like the whole supply chain issue, that's why we're taking a supply chain issue perspective and bringing in ETH Zurich, because it would be difficult to solve any particular part of the problem in isolation. This is also a war zone, just because that wasn't clear. Like that's a logistical challenge on top of things.
But I'd imagine these power quality issues are not confined to Congo, the same there.
No, certainly not. There has been one paper that I have read that is unpublished by a consulting group for the WHO that was out by the Gates Foundation that does power quality reliability monitoring at the scale at which we have done it here, and it's actually comparative, and they've done Kenya and Nigeria. And the long and the short of it is that the Congo is North Kivu at least. If you look at like the regulated entities, they're doing actually better than the national grid, or not as good as most of the national grid of Kenya, still better than the national grid of Nigeria. So that's kind of like a silver lining, I guess, if you're into the competition. But there is not a lot of literature, whether in the health facility electrification space or in the power system space, that does a tremendous amount of empirical longitudinal data collection around power quality and reliability in African power systems, whether it's national grids or microgrids or mini grids. We're talking about like not like a weak spot check of what the power quality is like, but like longitudinal, 2 minutes, every 2 minutes for a year. You get some seasonality. So that doesn't really, I haven't seen much of it. But of course, in Africa, PQR challenges are definitely a big deal.
And there's another anecdotal thing that we've talked about before, that the mini grid systems tend to actually get abandoned over time. So you might have a mini grid system to be all installed and to be all shiny and new. This happens in a lot of countries actually. Work for 3-4 years, there's no local input into the operation, the maintenance of the system. 3-4 years later, it's gone. Maybe the grid maybe arrives off some sort of fashion and it's poor quality as well. So mini grid system gets cast aside, all the equipment, and there's lots of investment and all that kind of stuff as well going on.
We have some where it's 13 months.
Yeah.
Where hardware system installed, zero plan for maintenance, not just for health clinics, but some of these trial mini grids, it's a matter of months to the survey in South Sudan. Within half a year, 70% were not working.
It's definitely, I mean, the technology is getting better all the time, which is my personal interest in it. It's really cool how things are evolving and maturing, and of course, mini grids really have an important role to play in SDG 7 in Africa and in the world. But there are definitely a lot of poorly planned projects happening right now, or conversations in the DRC sort of help us see how politics at a high level result in things being built in places where they have no business being built in the first place. You know, big 200 kilowatt system, not big, but 200 kilowatt system, can't find 10 houses to connect it to. Why? Politics. Some man in Kinshasa decided this was where
This is gonna go.
this is going to go. So that's the sad part of the story. But a lot of, like, in the mini grid debate, like, that shouldn't be held against the technology, in my view.
All right, just one last number you might want to, that is that in terms of thinking about how this worked in DRC and sister projects in Kenya and Tanzania, the rough estimate is 170,000 health clinics across that, from the smallest off-grid clinics to the biggest hospitals, and perhaps 100,000 don't have power, don't have reliable. So that 1 in 4 number kind of multiplies out. So if you can get it right and set up some demonstration, scalable, replicable projects, the potential impact and scale is just huge in terms of health delivery, but also other sustainable development.
You know, they're actually just public facilities. We don't even know how many private facilities there are. So about 170 public facilities, with 100,000 of them that don't have the right electricity. And that could number is almost double, at least 50%, extra towards public or private facilities that we big face.
Right, let's
So, yeah, thank you.
Okay, we have some great, opportunity. We can move from exciting to get ourselves in model 14. We will get back after we do this and we can have it on the phone. To try and help I heard that. What is the word? Yes. Just keep those here. Yeah, awesome. I'm not. I'm looking for that. Or, huge walk that. Sure.